and a women's research scholar at Harvard University. She completed her residency training at Northwestern University in Chicago, and then a fellowship in complex family planning here at the University of Utah last year. I have had the personal pleasure of training with Dr. Fay at both institutions. She is an incredibly thoughtful and compassionate clinician. In a prior life, she also worked as an intimate partner violence advocate and community educator. This interest in anti-violence and anti-oppression work continues in her current research, focused on reproductive coercion. Outside of work, she likes big dogs, tiny plants, fast recipes, and slow hikes. In today's session entitled More Than Informed, Trauma-Liberative Family Planning Practice, Dr. Fay will review key principles of compassionate family planning care for all clients, but especially for those individuals with a history of trauma. So without further ado, we will go ahead and close our pre-echo survey here. Erica, is it okay if I close that?
Yes.
Perfect. And then I will give the screen to Dr. Fay.
Great. Should I share these poll results? I have a little window that lets me do that.
You can share them if you'd like.
Yes. I mean, I found it super helpful. Okay, and then let me share my screen. All right. Yeah, I just need that. Okay. Everyone can see that? I'm looking at the time. Time will be my challenge today. Thank you so much for that very kind introduction, Amy. And you already shared our title. So my only disclosure is my current funding source, but I think there's also a content disclosure and an acknowledgement. One is that we'll be reviewing content around trauma, including triggering language. And so taking note and taking care on that front, but also that we are in the middle of a mass traumatizing event, which is COVID, particularly for clinicians. And so some of the, I think material might feel like a critique of care delivery when I imagine many of us feel burned out. And so thematically speaking, I just want to hold space for the presumption that everyone is doing the best that we can and really finding value and maybe even energy and thinking of new ways of creating wellness for ourselves and for our clients. So our agenda for today is to go through some background principles, some guiding principles for clinical discussions and physical exams, and then go through some concluding content, all in 30 minutes. And so jumping right in, what's the evidence base for some of the principles that we'll go through in this talk? And so essentially this is another disclosure slide of the many sources and types of wisdom. I think there are excellent data to support trauma-informed care based on conventional notions of research and the academic legacies of feminist work, and where I really draw from that in my role and identity as a clinician researcher. And this is also, I think, complemented by the generative spaces of social movements and advocacy work, which I feel connected to from what Amy shared of a prior career as an IPV advocate. And then my own and other personal histories of survivorship that I think inform what works for me and what makes sense for me. But all of this is to say that not all the content will ring true for everyone, but ideally the principles are widely translational. And that the growth of this field is really collaborative. So I'm always interested, particularly after seeing in that poll that many of you are already familiar with trauma-based care. I'm always interested in commentary from you all, and especially as the conceptualization of this work continues to evolve. Okay, so why do we have to think about this care so carefully and how we deliver that care? I think many of you are already on board in this front. But that this work is intimate and invasive, not just in terms of the type of exams that we do as sexual and reproductive health clinicians, but also in people who are proximal to this work, not necessarily as clinicians, but the nature of the topics and discussions that we have can feel very intimate and invasive as well. That similar actions outside of the clinic, like in people's sexual lives, demand consent. And so we hold ourselves to the same or likely higher standards. That some of the actions really mirror and easily trigger memories of prior violence. That the delivery of care really occurs in the context of historical and I would say also contemporary abuses, including the development of gynecologic technology through the violence against enslaved people, the legacy of eugenics, the collusion of criminal justice system with medicine against birthing people, forced sterilizations, biased counseling, all of which warrant a lecture in and of themselves. And that specific interventions like contraception or pregnancy management may be filtered through different lenses and mentioned here like political or cultural or faith-based lenses. So in the slides that follow, I think if the considerations seem really excessive, that we keep these considerations in mind. I think problematically because many of us do not expect safety outside of the healthcare clinic. We often don't expect safety inside of the clinic. So even without such expectations, even if you see an eye roll over time spent on introduction before intervention, the harms and possibility of re-traumatization can occur even if we don't have expectation for consent or for compassion. And then, so how can we expand considerations from those who disclose a history of trauma to all who seek sexual and reproductive care? And I think we can really draw upon this idea of universal design, which is the idea that when we make an environment accessible to all, we actually all benefit. Some further kind of points here is that trauma is prevalent. 89.7% of a national sample of adults in a study in 2013 met Diagnostic and Statistical Manual of Mental Disorders criteria for experiencing a traumatic event. So that means exposure to actual or threatened death, serious injury, or sexual violence. And so I think that really conveys the necessity, but also to me, brings an idea of gentleness to who our clients are and also to who our colleagues and who we are. Unpredictable impacts. So individuals react differently to the same traumatic event, and we'll talk more about screening later. But it means that being informed of someone's trauma history correlates little with its meaning to the individual and their adaptive behaviors. And then finally, disproportionate impact. So while anyone can experience, sorry, I'm just gonna make this window a little smaller. While anyone can experience trauma, who bears a disproportionate burden of that trauma is certainly worth recognizing. And when we speak of trauma, I think we often think of individual events, a violent attack or a specific natural disaster, but we really need to think of who is most vulnerable. And those are sexual, racial, ethnic minorities and people who have experienced prior trauma. So I think this is the thought process that really facilitates recognition of intergenerational trauma, institutionalized sexism, structural racism, and brings us to the notion that addressing trauma really requires an anti-oppression lens, which brings us to our terminology in terms of what we're, the talk is called today. Trauma-informed, I think, is one of the most common terms that's used in describing this sort of care. And it's really based in the acknowledgement that trauma impacts health and that clinicians should be capable of recognizing the signs and symptoms of trauma and operate in a way that avoids re-traumatizing clients. A lot of work has been done under the title of trauma-informed care that is broader and deeper than that. And so I think that's important to acknowledge, and also to acknowledge that I think we all also are already doing this, and that we alter our care for first pelvic exam, or for someone who does disclose a history of sexual trauma, or someone who reports no penetrative sexual activity, that we're already making these sort of considerations. There's also the term trauma responsive, and that really posits that it's insufficient to be just informed about someone's trauma history, and rather that we should integrate the presence of trauma into not just our counseling and care, but really respond preemptively to make care more welcoming for all. And it asks questions like, how can we make our actions more receptive and our clinical space more inviting? And then in terms of what we're talking about today, or in kind of a bigger picture, is trauma-liberative care is focused on ideas of power, and the idea that trauma that one person experiences from sexual violence or police brutality or from a clinician is all from the same origin. And it really feels the weight of what it might mean for someone to seek intimate, sensitive, reproductive care in that context, and focuses not just on how do we make this space more inviting, but how do we make this space theirs? How do we make this space the clients while they're here? And it's the transfer of power to the extent that we're able to in a clinical encounter. Okay, so we're going to end on all this like heavier theory work. And I think that often trauma work rightfully seems very overwhelming and too expansive to integrate pragmatically into clinical care, especially after the last slide. But there are, I think, some key principles that can really make a huge impact and correlate to 3 parts of a clinical encounter that we'll talk about today. So the first is transparency, and that's really this theme that I think about in terms of the discussion and counseling part of an encounter. Consistency, and that's what I really think about and apply in the actual examination. And then in closing and kind of finalizing that encounter, thinking thematically about humility. And so demystifying, I think what I mean here for transparency and giving a recommendation or discussing an intervention, I'm aiming to have my rationale as a clinician match an individual's goals. So the like little mantra that I think of is, this is why I think whatever, we should do an exam today. In terms of consistency, this is the principle that saying whatever is established in terms of agreements around evaluation and a physical examination are honored. So if you say stop, I will freeze. And in my head, the little mantra that correlates with this is this an emergency? And that really is a guiding principle around how we think about physically examining someone else. And then concluding with humility. So how can I adapt? How can I do better next time? I'm going to fly through this in the interest of time. So starting with our first principle around transparency and kind of counseling principles, it makes me think of in biology when we learn about form fits function, and this makes sense that for transparency, we're describing our form as a clinician so it can fit the function for that individual. We can start very basically with things like sharing our names and pronouns, and I think that's an invitation right away for discussion of language. And that this information doesn't necessarily need to be conveyed exclusively verbally, but also environmentally on your badge or in office materials. And it invites the client to do the same and offers you the opportunity to also use a principle of mimicking language. So do you hear the person saying the word partner? Do you hear the person using certain anatomical terms to describe their body? And that you can then use that as well. You can also, in this opportunity, like in first, starting your discussion with clients, is have a clinical mission statement. And this is something that I borrowed from Lisa Harris in the way that she talks about how abortion care providers can share a bit about their motivations and their journey to become an abortion care provider as a way to address harmful stereotypes about who abortion providers are. And I think that we can really adapt that to all clinicians. And your clinical mission statement is really an opportunity to define your job, and it's this definitive first act of transparency. So this is my example of something that I approximate with meeting patients. My goal is to create a safe and supportive space to talk about whatever they're here for, pregnancy options, and figure out what the best care looks like for you today. Everyone is different with different preferences and needs, and that can change over time. I have no agenda for any specific outcome other than you feeling in control of your health and happy with your care. Nothing that we do today is urgent. Nothing needs to be done today so that we can do whatever meets your goal. That little asterisk is in the setting of actually doing a procedure that could have some emergent component, that is my reminder that usually in the setting of describing the procedure, you can talk about, I don't anticipate anything emergent happening today, but if there is extra bleeding, the first steps are using an ultrasound and extra medications or whatever may be relevant to that point in time. Consider screening for trauma, intimate partner violence, sexual violence. ACOG has very clear guidelines around, yes, we should do this. I think that obviously it is important because it can really maximize your individualized care. It has medical legal implications for documentation. And many clients describe a sense of relief in being able to share that history. And it simply also identifies you as a caring clinician who is capable and interested in discussing these sort of needs. But in contrast, there are people who would say that the demand of disclosure of trauma is unethical, and sometimes the ask can actually feel like a demand, particularly for vulnerable populations. And that a key principle that's already come up in our talk today is that disclosure itself does not provide information on adaptations to exam, and lack of trauma history or lack of disclosure does not ensure comfort with an exam or a clinical encounter. So those are considerations. Especially if you're screening, but in general, it's important to define the limits to the bounds of the protected clinician-client relationship. So you need to know your state laws around being a mandated reporter. This is what most of the mandated reporting is for most states listed here. And also for when you can provide care without parental consent for adolescents. This is an important means of keeping power with the client so that they know the consequences of sharing particular information and the services that they can independently receive. Tap into individual wisdom. So usually I'm thinking about adaptations to the exam when I start with a broad question like, what are the parts of the visit that you're worried about today? But it can actually prompt really important information other than that, including, I am worried you're going to try to convince me to use contraception today, which is something that a patient disclosed in the past year to me. So that is important in terms of its broadness. You also can use positive language here. What has worked well in the past with these sort of visits? What's worked well when you felt anxious? What have you felt that worked well with this exam specifically, if you've had that type of exam before? All important things to learn in advance. And then you can establish some examination rules. This is borrowed from Stephanie Tillman, who's a midwife in Chicago. She says, some folks find it helpful to use specific words during the exam. If you say stop, that means that I freeze what I'm doing and I won't move until you tell me it's okay. Out means that I immediately and gently remove any instrument, if you're doing a speculum exam, or my hand, if you're doing a cervical exam. Would those words work for you? You can also here, I think, add in nonverbal cues. So if you close your legs, this is what this means to me. If someone shows signs of disassociating, so they're talking to you and they stop talking to you, that you can use those also as cues to change your actions during an exam. And then finally here for this section, really emphasizing the reasoning behind our recommendations. Sorry about that. And I think that I realized that a lot of times in teaching or obtaining consent, we focus on communicating the risks, benefits, and alternatives. But before all of that is really the reason for our recommendation. And then we can borrow, I think, from radiology is the ALARA principle, or as little or as low as reasonably possible. And that's with regard to imaging, including things like ultrasound, that presumably are completely safe, don't have any radiation, that still the principle is to minimize in interventionalism. And that's because we have an inability to measure all impacts. And that translates really nicely, I think, to the idea of trauma work, in that we want to have clear reasoning to do minimal interventionalism because it's not possible for us to measure all impacts, including harms, and when we intervene. I think also in terms of very clearly sharing our rationale for doing a pelvic exam, for doing a breast exam or a chest exam, is that it also is a check on aligning our recommendations with client goals. And so it acts as this mutual meeting point as well. So these are the things we just discussed. I'm just looking at the time. We're going to keep on. I'm going to go relatively quickly through this part as well, and then we can always ask questions at the end, which is really, in addition to those more general principles, there are specific thoughts around safety. One is identifying ourselves as a safe person. And I think that there is an uncomfortable similarity between clinicians and unsupportive or abusive partners or family members. Both can be angry or disappointed in a decision, e.g. not to have LARC. Both can continue a physical exam or physical action when there are verbal or physical cues to stop. And that's an upsetting thought, but the work that we do can also really be easy to elicit a reaction and emotions. So taking a personal inventory to check how we're feeling, to see if we have an agenda or we have a preference around what we want a particular client to choose is important, and something that Alyssa Perucci talks a lot about in her book. And so sometimes you can give yourself a little pop quiz that I'm actually going to skip today, but these are all scenarios where either I or my colleagues have had noticed a reaction to what we wanted for these people. And I think that that's important to emotion to trigger in a non-clinical setting so that you can memorize it and recognize it early when it does happen in a clinical encounter. With specific considerations around safety for certain aspects of sexual and reproductive health care, thinking about people who are concerned that they have limited safety with a sexual partner, like someone who's refusing to use condoms, or coercing or forcing sexual activity. You can consider greater frequency of testing, pre-exposure prophylaxis, safety of communicating results or delivery, expedited partner therapy. For someone who's worried about a family member or partner interfering with contraception or access to clinical care, some considerations include more tamper-proof methods like an arm implant, an IUD, or Depo-Provera. For those whose access to getting an IUD removed is being obstructed by a family member or partner, coaching through self-removal. Someone who's worried that their menses are being monitored, talking about non-hormonal methods or placebo week for pills. For people who don't feel like they have supportive or do have an abusive family member or partner and they're worried about pregnancy management, seeing if they can identify someone who is a support person and making healthy decisions, people who are certain that they want to continue with prenatal care, but have someone who's obstructing their access to care, talking about walk-in or virtual appointments, hospital alias or security list when they are in the hospital, and then bundling as much care as possible when they are able to access care. For people who are worried about unsupportive family or abusive family or partners who want abortion care, talking about if they're in the first trimester, isolating care to a single procedural encounter, or if they need something to look like a miscarriage, talking about medication management and also the possibility that that medication is tampered with at home. And then we'll talk more about warm referrals in a little bit, but basically the theme here is creativity, mutual brainstorming, and delivering care that can meet goals and safety needs, and acknowledging that we are clinicians in one regard and that there's a host of community resources to address very important needs around larger safety issues as well. Let me look at my time. Okay, for the exam, we're going to go through this relatively quickly so that we hopefully have more time to ask questions. In our theme here is consistency. So we've really established some parameters prior to initiating the exam. And those are ones that we're going to show we are trustworthy and hold to during an examination. So we've talked about maybe some words to use. We've reminded ourselves if there is a possibility of anything urgent, and really thinking about the dignity of risk in the setting of an urgent or emergent scenario so that we can maintain the ethical principle of autonomy. We can review preferences around breathing exercises, relaxation, but not everyone finds that helpful. So really maintaining power with the client and choosing whether or not these are helpful. Same goes for using music or videos on your phone. Some folks really want a live narrative description of what to anticipate, including sensations of pressure or cold instruments. Others really want to focus internally and not have that level of detail. Same goes for seeing or handling instruments. Some folks feel like that actually allows for a level of mastery and connection with what's going to happen. Other folks do not want that. You can invite as much participation as desired, and have the client spread their labia, self-place speculum or probe, self-collect a swab if that's something that they find helpful. You can offer a stirrup-free exam. So that means using the lower portion of the exam table to have feet sole down or frog leg position. In the idea being that we're really trying to minimize any restrictions on freedom of movement. So the same would go if you need pelvic tilt, not having the client place their hands underneath their lower back, because that can also feel like you're restraining that person. And that reminds us, and I'm very guilty of this, of immediately assisting people into certain clinical positions and really letting people move their body for themselves unless they ask for help. Choosing language carefully. So reconsider feel and touch as verbs. So I'm going to feel breast tissue, or I'm going to touch the uterus. I was taught in medical school, ICE, inspect, check, or examine, which I think is fine, but can feel a little bit sterile or cold. And so I've kind of arrived at notice. You'll notice a hand on your thigh, which I'm interested to know what other people think about. Avoid things like just relax, and you can use something like let your knees fall out to the side when you're ready. Avoid things like do this for me, scooch to the end of the bed for me, or other diminutives like honey or babe, because that leads to accidental sexualization or parallel to language use during assaults. You can be attentive to other parallels. So do you say examination bed or examination table? And seeing if there are other ways we can adjust our language in that sense. The point, I think, and purpose here is to prove in each action that you can abide by the principles that you mutually established, and that you're as able, yielding, and honoring power to the client. And I think one of the most important recent examples for me was when there's an extramural transfer of a home birth. And it was very important to that family to have delayed cord clamping. But when the baby was born, the baby really needed resuscitation. So the pediatric team was able to adapt and able to resuscitate at the bedside without having the cord cut. So that brings us to our little mantra for the exam section, which is that having consistency and demonstrating trustworthiness is a low stakes and high reward intervention, because infrequently we are facing emergencies, particularly outpatient. And when we do, there often is a way of maintaining that honor in ways that not only don't jeopardize care, but actually preserve the quality of that care. So my little mantra during exams is, this is not an emergency. And then finally, if it's okay, like 5 minutes here, please tell me, moderator / Amy, if 5 minutes is too much, is the closing of that clinical encounter. So Utah taught me about the contraceptive campsite rule, which I love. And that builds off of the regular campsite rule, which is that we leave a campsite better than when you found it. And the same goes for contraceptive counseling. And my point today would be, for all clinical encounters, is that we leave individuals better off than when we found them. But how do we know if we were successful? So I think debriefing is largely integrated into medical education. And so we always debrief after a delivery or a surgery with a trainee. But do we routinely do that with clients in clinical encounters, particularly because of their unique authority in determining successful care delivery? So asking things like, how did that go? Is there anything I could have done differently? And sometimes it can be hard for clients to give you that feedback. So if you have the capacity for other ways of contact, you can say things like, if you think of something later, send me a message through the portal. And just as we document things like, oh, this person benefited from using a grave speculum or a pediatric speculum, we can also document what worked well and what didn't. So we did the pelvic exam in a frog leg position with self-placement of the speculum, and the client had music on their phone. So that offers a starting off point for future clinical encounters to confirm that that's still a preference. clinical trial of one. So really emphasizing in the ending the clinical encounter, the limitations of medicine. So during counseling, you've shared the pros and cons and likelihoods of success of a contraceptive method or a pelvic pain remedy, but you invite ongoing discussion, revisit your commitment to wellness and goodness of fit by having follow-up or establishing your expectation for comments around trying something different. And then knowing your community resources is one of my final points. So I think the presentation here has really been, how do we best support care delivery in a holistic manner for clients rather than be gatekeepers to wellness. But I think at a minimum, we're really trying to just not add to trauma and acknowledge the reality that we may not be the people source of anything but really a pill prescription, and that people will seek care and support from alternative sites. And so knowing your local advocacy and social justice organizations is really important. Making warm handoffs is a way for you to endorse that seeking of a better fit of support elsewhere. And for people who have difficulty accessing the phone or internet safely for a host of reasons, your office may actually offer the safest place to initiate contact. Okay, so that's our little summary of that final point. And so in conclusion, I think trauma-liberative care is a natural corollary to sexual and reproductive health care. Clinicians in SRH care are experts in highly individualized, preference-sensitive care with general principles that apply, like reviewing contraceptive efficacy, reviewing contraceptive bleeding profile, but the relative impact and importance of that information is unique to each patient. So that means that this is really the skill set that we've developed around conventional care applies really nicely here. In our discussions and counseling, we're thinking about transparency, matching our recommendations to client goals, and using our little mantra of how is my rationale justified. For our exams, thinking about consistency, the parameters to the exam can be trusted, including when to stop the exam. And rarely in our work is there a care so urgent that it eliminates the need for comfort or consent. So our little mantra is this an emergency? And then finally, in maintenance of the relationship, concluding with humility and debriefing and decentering ourselves and making space for individualized care, and creating opportunities to be called in. How can I do better next time? But also good things like, how can I congratulate myself on good work I just did? Okay, so slightly over, but that is a whirlwind review. I'm going to stop this so that maybe there's time for questions, and then case presentation. Questions?
Thank you so much, Catherine. I will let other people ask questions. Oh, wait, I don't want to jump if anybody else has a question.
I have a question.
Okay, Jen gets to go first.
Hi, hello, Catherine. Long time no see. Thank you so much for a fantastic presentation. Somebody else also wants to say hi. So my question for you is, in the setting of kind of more of these urgent or emergent situations. So say you're placing an IUD for somebody, you've like set the stage, you've done all these things, and you are like you have the IUD inserter through the internal os, and they tell you to stop, or they tell you to take everything out. How do you navigate those moments where you're like, I just need 10 more seconds, and this is done for you?
I know. I think that that's really complicated, and certainly in contradiction to, I feel like, my medical training, which would be to be like, in the end, the patient's gonna like be grateful that you took 10 seconds and you just did it. That within the trauma-informed care world, that would be not okay. So if you've established, I mean, that's why I think those words are actually really helpful. So if the person says stop, then that gives you an opportunity to freeze, and then for you to say, in less than 10 seconds, the IUD would be in place. I'm happy to do that in 10 seconds, or we can stop and to say next time we'll try something different. If they say out, and that is what was agreed upon as the reason to abandon the procedure, then you abandon the procedure. And it means that that you're done, and that IUD goes in the trash, and that you have a moment to then think about a new plan. But that, I think that is why, even though it seems excessive to have those words discussed in advance, means that there's absolute clarity in moments when it feels like the right thing is to finish the procedure, but you both know that because of the discussion you already had, that actually the right thing is to end the procedure.
One question I have had is, how do you balance the ideals of performing trauma-liberative care with the other demands that are placed on us as clinicians? So to get through a checklist of recommended care or treatment, to do this in a time frame, to be good stewards of resources. I mean, it just like breaks my heart to throw out a IUD, right? From a economic standpoint and everything like that, if it's already opened. But obviously you don't want to harm patients. And so how do you make space for all of these things?
Yeah, I think that is, I think perpetually a challenge for everything that a clinician does, is how do we have time, and what is the like tyranny of a 15-minute visit for everything that we're trying to do. I think folks in trauma work would say that this is actually time saved by having this investment up front. It actually, I think, streamlines a lot of concerns around complications that might come up later. By being clear about what to expect next, it actually, I think, seamlessly makes things like the physical exam smoother, and counseling or concerns after already addressed. I also think that so much of medical training is around multitasking and efficiency. And that in generating a script, which is kind of why I have that like clinical mission statement, that is legitimately 5 seconds of 3 sentences that you can say that actually sets a tone and addresses a lot of concerns very efficiently. And so I'm not totally sold on the idea that creating time up front to have a very clear presentation of your ideas around what care delivery should look like and adaptations for that patient actually is going to take more time. I think it would take less. It just takes practice to get there, as in all things.
Awesome. Well, thank you so much. I will have more chance to ask Dr. Fay questions in just a few minutes. I do want to quickly run through our case presentation. Today, this is going to be like whiplash, completely different topic, but hopefully something that is topical to our current COVID situation. I'm just going to share some slides real quick here. Bye.